Hi, my name is Dr. Yasser Osman and I'm going to talk about electrolyte disorders. Electrolyte disorders, for the safe practice of anesthesia, electrolyte problems should be identified and corrected pre-operatively. Electrolyte disorders can affect many organs like brain, neuromuscular system, ventilatory system, and cardiac functions. Sodium. Sodium is the predominant extracellular cation. Normal serum value is between 135 to 145 millimole per liter. The daily requirement of sodium is 1 to 2 millimole per kilogram per day. Sodium content is regulated by a balance between intake and excretion by the kidneys. The renal excretion of sodium is controlled by several neurohormonal mechanisms, including aldosterone, atrial natriuretic peptide, angiotensin II, parathormone, and alpha adrenergic stimulation. Disorder of sodium concentration usually result from relative excess or deficit of water. The clinical manifestations of hypo and hypernatremia are largely attributed to changes in cell volume. Hyponatremia is associated with hypotonicity and intracellular volume expansion because water will pass from the extracellular space to the intracellular space, whereas hypernatremia results in intracellular volume contraction, i.e. cell will shrink because the reverse will happen. The water will pass from the inside the cell to the outside area, which is the extracellular fluid. Hypernatremia means sodium more than 145 millimole per liter. It indicates an absolute or relative water deficit and is always associated with hyperosmolarity. Causes: water deficit, inadequate intake, excess loss, for example, renal, diabetes insipidus and osmotic diuresis, extrarenal, for example, sweat, respiration, diarrhea, and fever. Excess sodium, which is rare, increased intake, hypertonic saline infusion or sodium bicarbonate infusion, inadequate excretion, for example, renal failure. Signs and symptoms of increased sodium, mainly related to cellular dehydration and includes mental changes like confusion, hyperreflexia, seizures, hypovolemia, and thirst management, increased water administration, whether oral or IV in the form of 5% dextrose. Restrict sodium intake, increase sodium excretion by diuretics. Treatment of the cause, for example, diabetes. Hyponatremia, serum sodium less than 135 millimole per liter, is the most common electrolyte disorder in hospitalized patients. Hyponatremia is most often the result of excess total body water, dilutional hyponatremia. Causes: water excess, for example, increased water intake, psychogenic, iatrogenic, transurethral resection of the prostate, this is an operation, excessive 5 dextrose infusion. Inadequate water excretion, for example, in renal failure, hepatic failure, cardiac failure, hypothyroidism, excess antidiuretic hormone secretion. Sodium deficiency. Renal loss, for example, in diuretics, or aldosterone deficiency. Extrarenal loss, for example, in sweat and gastrointestinal losses. Inadequate sodium intake. Signs and symptoms depend on the rate and severity of hyponatremia. Serious manifestations usually appear when serum sodium is less than 120 millimole per liter. Acute cerebral manifestation is related to brain edema, which leads to metabolic encephalopathy, which can be both irreversible and fatal. A decrease in plasma sodium leads to cerebral edema, which leads to all the signs and symptoms of hyponatremia, which includes mental changes, muscle cramps, weakness, hyperreflexia, and coma. Management. Correct the primary cause. In mild hyponatremia, that means that sodium is less than 135 millimole per liter. Correct hypovolemia if present. Increase sodium intake and restrict water intake. In moderate hyponatremia, correct hypovolemia, saline 0.9% intravenously, restrict water intake. In severe hyponatremia, sodium is less than 120 millimole per liter, plus a rapid fall in the sodium concentration, plus or minus mental changes. Correct hypovolemia, saline 0.9% or hypertonic saline 3% may be given. Diuretic, once plasma sodium is more than 125 millimole per liter, water restriction alone is usually sufficient. Potassium. Potassium is the predominant intracellular cation. Extracellular potassium, serum potassium, concentration is 3.5 to 5 millimole per liter. Potassium is regulated in the body by three hormones: aldosterone, epinephrine, and insulin. Potassium plays an important role in cell membrane physiology, especially in the central nervous system and heart. The daily requirement of potassium is 1 to 2 millimole per kilogram per. Potassium disorders and anesthesia. Both hypo and hypercalemia can cause life-threatening dysrhythmias. Abnormalities in serum potassium are a common clinical electrolyte disturbance. Digitalis toxicity is commonly associated with hypokalemia. Interaction with muscle relaxant, muscle weakness, and inability to reverse the muscle relaxant effect. Therefore, serum potassium should be between 3 to 5.5 millimole per liter before any elective surgery. Because of its lethal effect, hypercalemia more than 6 millimole per liter should always be treated. Intravenous replacement of potassium should usually be reserved for patients with or at risk of serious ECG changes or muscle weakness, i.e. the oral therapy is safest. Potassium chloride ampoule 5 ml contains 10 millimole, is extremely hyperosmotic and must be diluted before use. Potassium should be given in large veins to avoid sclerosis and thrombosis. The use of central venous catheter can cause hyperkalemic arrhythmias and are best avoided. Potassium should not be given in dextrose solution because it stimulates insulin release, further lowering serum potassium. Hypokalemia, serum potassium less than 3.5 millimole per liter, causes decreased intake, potassium shift into the cells in the case of correction of acidosis, insulin glucose administration, alkalosis, respiratory or metabolic, acute stress, increased catecholamines, hypothermia, and another cause is increased losses in hyperaldosteronism, diuretics, renal tubular acidosis, vomiting, nasogastric suction, and diarrhea. Magnesium deficiency. Clinical manifestations: cardiovascular changes, dysrhythmias, ECG changes, U-wave appearance, ST depression, T-wave depression or flattening, like in this picture, neuromuscular changes, weakness, paralysis, hyporeflexia, depression, smooth muscle effect, constipation, and ileus. Management: correct precipitating factor, example alkalosis, avoid hyperventilation in hypokalemic patient, intravenous or oral potassium chloride for mild hypokalemia, potassium 2.5 to 3.5 millimole per liter, oral potassium chloride, intravenous 10 to 20 millimole potassium chloride to each liter of fluid. For severe hypokalemia, if potassium is less than 2.5 millimole per liter or paralysis or ECG changes is present, intravenous infusion of potassium chloride at a rate of 20 to 40 millimole per hour under ECG monitoring and serum potassium level to avoid hyperkalemia. Hyperkalemia means serum potassium more than 5 millimole per liter, while in severe hyperkalemia, serum potassium is more than 7 millimole per liter, and or presence of ECG changes. Causes: increase intake, use potassium supplement, rapid massive blood transfusion, aqueous penicillin, decrease excretion, angiotensin converting enzyme inhibitor, aldosterone deficiency, potassium sparing diuretics, renal failure, extracellular redistribution, beta blockers, acidosis, cellular destruction, for example, hemolysis and succinylcholine. Clinical manifestations: cardiovascular changes, dysrhythmias, asystole, heart block, ECG changes like in this picture, tall peaked T wave, PR interval prolongation, decreased P wave, QRS widening, neuromuscular changes, paresthesia and weakness, paralysis and confusion. The faster the rise of potassium, the higher the serum level. The stronger the evidence of cardiotoxicity, the more aggressive therapy should be. Management: eliminate the cause, i.e. stop potassium intake. Calcium chloride, it does not reduce the plasma potassium, but it stabilizes the myocardium against arrhythmias. Transfer of potassium into the cells by insulin glucose 50 gram plus 10 to 20 unit of insulin given IV. Sodium bicarbonate 50 to 100 millimole IV. Hyperventilation, beta 2 adrenergic stimulant, removal of potassium from the body, diuretics 40 milligram IV furosemide, potassium exchangerism oral or enema, enhance potassium clearance across the intestinal mucosa, and hemofiltration or hemodialysis may be needed in resistant cases. Calcium. Almost all of the body calcium is present in bones. The normal daily requirement of calcium is 15 to 20 millimole. The normal serum calcium level is 2.5 to 255 millimole per liter. The ionized form is 1.15 millimole per liter. Ionized calcium is physiologically more important than total calcium. The total serum calcium is usually measured, but ionized calcium is a better indicator for calcium status in the critically ill patient. Hypocalcemia causes hypoparathyroidism, septic shock, acute pancreatitis, rhabdomyolysis. Clinical feature: tetany, cramps, mental changes, decrease in cardiac output. Management: intravenous calcium chloride or gluconate. Hypercalcemia causes hyperparathyroidism, thyrotoxicosis, renal failure, malignancy, thiazide diuretics, prolonged immobilization. Clinical feature: nausea, vomiting, pancreatitis, polyuria, polydipsia, muscular weakness, mental changes, and ectopic calcification. Management: treatment of the cause, general measures, optimize IV volume, diuretics to promote calcium excretion, others like steroids and calcitonin. Magnesium. Magnesium is primary and intracellular ion and has important role in the transfer, storage, and utilization of energy. Plasma concentration 0.7 to 0.95 millimole per liter. The daily requirement is 8 to 20 millimole, and urinary loss is the major source of excretion. Magnesium therapy may be used for prevention of eclampsia, in the treatment of atrial fibrillation, in controlling the rate and rhythm, during cardiopulmonary bypass and after cardiac surgery, can be used nebulized or intravenous in acute severe asthma. Magnesium may prevent delayed cerebral ischemia due to vasospasm in subarachnoid hemorrhage. Hypomagnesemia, less than 0.7 millimole per liter, causes GIT and renal losses and redistribution. Renal causes: drugs, proton pump inhibitor and diuretics, osmotic diuresis as in diabetes. GIT causes: reduced intake, reduced absorption, malabsorption syndrome, diarrhea and laxative. Others: alcoholism and endocrine disease as diabetes and hypothyroidism. Clinical features: less than 0.3 millimole per liter may be considered as medical emergency. Tremors, agitation, confusion, and tachyarrhythmias can occur. It is often associated with resistant hypokalemia and hypocalcemia. Management. Treatment of severe cases is usually intravenously. 10 mmol of magnesium sulfate as a bolus over 5 minutes, followed by 20 to 60 millimol per day. Hypermagnesemia causes excessive administration of magnesium salt or conventional dose of magnesium in the presence of renal failure. Clinical features: drowsiness, hyporeflexia and coma, vasodilatation and hypotension, conduction defects, and asystole. Management: increase excretion up to daily dialysis. IV calcium chloride for treating cardiac conduction defect. Thank you. I hope you enjoyed this lecture.